Everyone. So before we jump into our today's session, let me announce last week's winners. So we have a very long list. Uh, First of all, it is Dr. Shantanu Kumar Bhattacharya from Kolkata, West Bengal. Then Dr. Vinay Desai from Thane, Maharashtra. Dr. Surjit Kalsi from Noida, Uttar Pradesh. Then Dr. Anand Purandare from Mumbai. Dr. Gangadhar Rath from Bhubaneswar, Odisha. Dr. Bharat Praveen from Surat, Dr. Nakul Bansal from Panchkula, Haryana, Dr. Dheeraj Kumar Haldar from Kolkata, West Bengal, Dr. Umesh Kumar Malhotra, New Delhi, Dr. Shashi Khare from Bhopal, Madhya Pradesh, Dr. Satish Kumar Jain from Bangalore, Karnataka, Dr. Rajiv Handa from Delhi, Dr. Anshul Singhai from Bhilai, Chhattisgarh, Dr. Shashikant Shende from Mumbai, Maharashtra, Dr. Sumita Sharma from New Delhi, Dr. Sanjeev Puri from Hoshiarpur, Punjab. That's a very long list, and congratulations to all the winners. So, before we run into our session today, Karan Sharma, on behalf of FDC, the makers of Enerzel, I welcome you all to our Sunday 9 p.m. show of Diabetes Talk with Dr. Sanjay Kalra. So let me call upon stage one of our most celebrated doctors from the country, Dr. Sanjay Kalra. Dr. Sanjay Kalra is a DM endocrinologist who has done his DM endocrinology from the prestigious AIMS Institute, New Delhi. Along with that, Dr. Sanjay Kalra not just has many prestigious awards and accolades to his name, but has also been a panel member for many authoritative studies and has also been a chairperson for many key medical and doctor associations for the welfare of the humankind. Sir, on behalf of our audience tonight, let me give you a very warm welcome. Good evening, sir. How are you doing tonight, sir?
Good evening, Karan, and it's great being with you. It's a nice day today. We had a lot of rain in Karnal, so the weather
Yes,
is
sir.
pleasant. It's quite cool here.
That's very good. In fact, rains are pouring across the country, and it's good for everyone. So the stage is all yours, sir.
Rains bring with them lots of good things and sometimes a few bad things. And then there are many things that come with rain which can be considered good or bad depending on which side of the table you are on.
Right, sir.
One good thing that comes with rains is the snacks and the savories that we all enjoy across the
Right,
country. So whether it
right,
is samosas or bread pakoras or fritters or maybe fried fish, whatever it is that you like, that is something that is used quite frequently uh,
right,
in the monsoon season.
right, sir.
The only challenge is that if you take a lot of saturated fat, that is a lot of ghee, and a lot of salt, and a
Hmm.
lot of sugar, that's
Right,
calories, then sometimes we can get in trouble. And these
right,
things, the saturated fats, the sugar, the salt, all these S's can sometimes get our patient to land up in S for stroke. So today we'll talk about how to prevent cerebrovascular disease.
right, sir. So that was a very interesting pre-note, sir. Absolutely, what you've shared with us is very important to all our audience. So thank you, sir, and the stage is all yours.
Thank you. Now, in the diabetes clinic, our main aim is to prevent disease, right? Of course, we are trying to manage diabetes. We are trying to control the glucose. Patients think we are treating them. The main aim is we have to keep on telling them again and again that we are trying to prevent disease in you. What kind of disease are we trying to prevent? First of all, acute disease, symptoms, polyuric symptoms, osmotic symptoms, polyuria, polydipsia, polyphagia. Once we've taken care of that, then we want to prevent the subacute complications like maybe infections, diabetic foot tuberculosis. And then after that, we want to prevent vascular complications. In general, when we speak of vascular disease, we always tend to speak of the coronary vascular bed, heart disease. But there are other vascular beds which are equally important: femoral, pudendal, cerebrovascular. So today, let's focus our attention on cerebrovascular risk or stroke risk reduction. Now, stroke is actually quite common, and the incidence of stroke, the prevalence increases with aging, with obesity, and with diabetes. 2.8% is the prevalence of stroke in diabetes across the world. In India, we have our map, and there is something known as chicken's neck. Chicken's neck is important for the epidemiology of stroke as well. Towards the east, stroke or cerebrovascular disease is more common. Towards the west, cardiovascular disease or coronary artery disease is more common. When you see data from Japan, Korea, Taiwan, you find that their stroke rates are very high. Cardiac rates are high. They have begun going up just now. And when you go to the Middle East, stroke is not so common. It is coronary artery disease, MI, which is the main driver of vascular disease. Different types of metabolic dysfunctions actually promote cardiovascular and cerebrovascular dysfunction. Hyperglycemia per se and hypoglycemia also. Hyperglycemia, hypoglycemia, and glycemic variability. All three lead to endothelial dysfunction. When there is endothelial dysfunction, there is a pro-inflammatory response. Interleukin 6 CRP increase, and that causes inflammation in the cerebrovascular bed. There is also oxidative stress, which reduces the ability of the cells to fight disease. And then there is altered production of vasoactive markers. NO, nitrous oxide, for example, which is a vasodilator, is reduced in concentration in patients with endothelial dysfunction. All these lead to stroke. How do we classify stroke? The simplest way would be to classify as ischemic or hemorrhagic. So most people will have ischemic stroke. That means there is ischemia, less blood reaches the brain. Some people will have a hemorrhagic stroke. The blood pressure becomes so high, or the wall of the blood vessels becomes so thin that it begins to bleed. That is hemorrhagic stroke. The prognosis is much poorer here. In ischemic stroke, there are two types of stroke, thrombotic and embolic. Either the ischemia will occur because of a thrombus that has developed locally, or an embolus which comes from a far off place, maybe from the heart, or maybe from an aortic aneurysm. So we should be able to differentiate between ischemic and hemorrhagic strokes. In ischemic, we should be able to know whether we are working to prevent thrombotic or embolic stroke. Now, how do you prevent stroke? That is our aim. So remember the S's: absolute stoppage of smoking, no spirits. Now, we are fond of saying that 30 ml per day in women and 60 ml per day in men is a safe limit. But the WHO very clearly mentions that spirits or alcohol is dangerous for health in any amount. Excessive salt is one of the precipitating factors for cerebrovascular disease, especially in Eastern Asia. Stoutness or obesity is a risk factor which can be modified. And stress management is important. Another S we would like to add to this is sleep hygiene. So do remember to sleep properly. Smoking, spirits, salt, stoutness, stress hygiene, and sleep management. And don't forget the major S, that is sugar. It's not just non-pharmacological therapy that you have to give. If we are able to manage all aspects of vascular metabolic health, we can actually prevent stroke. So the first aspect is good glucose control. Two things here. Number one, good glucose control without causing hypoglycemia. Number two, good glucose control using drugs that are proven to have safety and efficacy and benefit in cardiovascular outcome trials. The two classes of drugs will be SGLT2 inhibitors and GLP-1 receptor agonists. SGLT2 inhibitors and GLP-1 receptor agonists. Another drug which is very good for preventing the risk of stroke in persons with pre-diabetes is pioglitazone. So pioglitazone, when given to persons with pre-diabetes, was able to prevent the risk of stroke. So the first is glycemic control, SGLT2 inhibitors, GLP-1RA, pioglitazone. Avoid hypoglycemia at all costs. Hypoglycemia is a stroke mimetic. It is a mimetic or a differential diagnosis of TIA, transient ischemic attack. It can also precipitate transient ischemic attack or stroke. Hypoglycemia is also arrhythmogenic. During the daytime, hypoglycemia can precipitate a tachyarrhythmia. At night, it can promote bradyarrhythmia. And these two can promote stroke. The second aspect is blood pressure control. Control blood pressure. Do not cause hypotension or postural hypotension. Postural hypertension is again a differential diagnosis of stroke. Dizziness will occur in postural hypotension. Dizziness will occur in stroke. Headache can occur in postural hypotension. Headache can occur in stroke as well. So avoid hypotension at all costs. Prefer ACE inhibitor or ARB. The third aspect is cholesterol. Now, statin should be prescribed to every person with diabetes above the age of 40, unless there is a contraindication. Ideally, advise moderate intensity statin, that is rosuvastatin 20 or atorva 40. In my OPD, I am guilty. I use lower doses usually, but then the cholesterol usually does come to normal. Try to target a 30% reduction in LDL in all patients. In those who are at high risk, those who have already had a stroke, those who have already had a myocardial infarction, or those who have multiple risk factors, then we need to target an LDL less than 70. The target is LDL less than 70. The fourth is antiplatelet therapy. Now, antiplatelet therapy, that is aspirin, is indicated only for those with established ASCVD, established atherosclerotic cardiovascular disease, which can be cerebrovascular, cardiovascular, or femoral. So remember the four things: glucose, blood pressure, cholesterol control, and antiplatelet therapy. Cholesterol control for everyone above the age of 40, antiplatelet therapy only for those with established ASCVD. We should also be aware of our targets. Repeatedly, we have said control diabetes but do not cause hypoglycemia. Control blood pressure but do not cause hypotension. So be aware of safety as well. Now, so far, our discussion has revolved around preventing thrombotic stroke. But embolic stroke is also common, especially in persons with atrial fibrillation. How do you view persons with atrial fibrillation? You can have persons with atrial fibrillation and valvular heart disease, or non-valvular atrial fibrillation, that is without valvular heart disease. When we are using the word valvular heart disease or valvular non-valvular, we are actually talking about the mitral valve. So if the person has mitral stenosis or mitral regurgitation or both, that is a valvular atrial fibrillation, if atrial fibrillation is present. If the person has a normal mitral valve, even if the tricuspid or aortic valve are damaged, even then we will call it non-valvular. It is important to know this because atrial fibrillation and valvular heart disease will have a different preventive strategy, while those with non-valvular heart disease will have a different preventive strategy. How do you prevent? How do you decide what to do? You use risk stratification scores, and one is called CHADS2. Those with valvular heart disease will get warfarin, that is the drug of choice, unless it is contraindicated. For warfarin, I would strongly suggest that we allow our colleagues in cardiology to titrate the dose because there is a high risk of bleeding. It takes time to work, and you need someone to do the investigations repeatedly, especially in the first few months. So, for valvular heart disease and atrial fibrillation, warfarin is the drug of choice. For non-valvular heart disease, NOACs are the drug of choice. NOACs are novel oral anticoagulant drugs. You can also call them DOACs, direct anticoagulant drugs. Three types are there: dabigatran, apixaban, and rivaroxaban. All are easily available in India. These are the drug of choice for non-valvular atrial fibrillation. Why do we prescribe them? To prevent embolic stroke. In the vast majority of patients, we would want to use dabigatran. The routine dose would be 110 milligram BD. In those who are elderly or those who have renal dysfunction, apixaban will be the drug of choice, 2.5 or 5 milligram BD. In case your patient wants a once daily dosage, then rivaroxaban, 20 or 50 milligram once a day. They are all oral drugs, all are safe to use, not much of monitoring is required. Do consult your colleague in cardiology or neurology before prescribing, but you can monitor later on yourself. Dabigatran is the one that is used most often. Apixaban is preferred for elderly and renal dysfunction. Rivaroxaban is preferred if a once daily dose is required. Very rarely a surgical treatment will be required. I honestly do not have experience with either diagnosis or monitoring or follow-up of such patients. So today we focused on the brain, the cardiovascular, the cerebrovascular system. And let's see some questions. Let's see if we are able to think from a brain point of view, from a cerebrovascular point of view. So our first question is the earliest vascular abnormality. The first one that is observed in type 2 diabetes patients is platelet dysfunction, vasoconstriction of blood vessels, endothelial dysfunction, or inflammatory state, which is the first one to manifest itself in type 2 diabetes. Dysfunction of the platelets, vasoconstriction of the blood vessels, dysfunction of the endothelium, or a pro inflammatory state. Our next question, a long one. The primary way and the best way to manage stroke, after all that we have discussed, is which of it is these is it? In type 2 diabetes, number one, control BP to less than 130 by 80. Choice B, long term intensive glycemic control. Number C, initiating statin therapy when LDL is more than 100. And D, 30 minutes of low intensity physical activity. So let's repeat, which is the primary and best way to prevent stroke? A, controlling BP to less than 130 by 80. B, long-term intensive glucose control. C, initiating statin when LDL is more than 100. And D, 30 minutes of low intensity physical activity. Low intensity physical activity. These are our questions for today. And now let's go to the questions from the audience. Lots of questions, and thanks everybody. Thank you, Dr. Vijay Kaniyesh, for your kind words. Let me take the questions one by one. From Jenny Ortega. Hi, Doc, how are you? How to differentiate ischemic and hemorrhagic stroke? Hemorrhagic stroke will usually present with very high BP and a very sudden onset, and the patient will be sick. High BP, very high BP, and maybe altered sensorium when the patient comes to you. Severe headache. Ischemic stroke, of course, it will be a sudden presentation, but the patient won't be very sick, won't be complaining of headache. There may or may not be altered sensorium. Another question is, what are the atypical presentations of stroke? Okay, so cognitive dysfunction, loss of memory, headache, dizziness. These are the three common ones. Dizziness, loss of memory or cognitive dysfunction, headache. Other atypical presentations will be related to different parts of the body. Maybe trigeminal neuralgia, wrist drop, foot drop, and you think it's a local neuropathy, a compressive neuropathy, maybe a radiculopathy, a myelopathy, but actually it is a stroke that is in evolution. Now, when we were students, the definition was transient ischemic attack is something where the symptoms last less than 24 hours. Stroke is when the symptoms last more than 24 hours. So you would diagnose after 24 hours. But now our colleagues in in neurology, if you are able to get your patient within 4 hours to them, they sort of dissolve the clot. They use clot buster drugs to dissolve the clot. You just have to get the patient within 4 hours to the neuro ICU. And therefore, you need earlier diagnosis. So that is why this comment by Dr. Ortega is well taken. You need to be aware of the atypical presentations as well. You have to diagnose, you have to suspect, you have to diagnose, you have to confirm the diagnosis with imaging, and you have to get the treatment done within 4 hours. If it's a 50-year-old, 55-year-old lady with diabetes and weakness of the upper limb and lower limb and deviation of the mouth. Okay, so had it been only deviation of the mouth, we would have thought of Bell's palsy. But now, since it is a hemiparesis, the initial step is the investigation, get an MRI done and rush the patient to the ICU. How long to take aspirin? This question is from Dr. Vijay. Thanks. So if it is hemorrhagic stroke, it is contraindicated. Aspirin is contraindicated. Though some people do say that you can begin aspirin after a year. In a patient with thrombotic stroke, aspirin should be taken lifelong. There is no fixed criteria for age, like stop it at 75, do not start at 75. It's about the frailty of the patient. But continue lifelong if it is embolic stroke or if it is thrombotic stroke. If in a CT brain we find small vessel occlusive disease, if it is generalized, then usually there will be a dementia. It will be ischemic dementia. So you do the best possible that you can. If it is a specific occlusive disease and the onset of symptoms is within 4 hours, then again refer to neurology immediately. Otherwise, you have to start aspirin and continue that lifelong. And you do the other things: glucose, blood pressure, cholesterol control. Warm greeting to Dr. Anshul from Chhattisgarh. And Dr. Mahesh asked about pitavastatin. This is a good statin to use, but it is not recommended by most guidelines. It is used as a second line drug. Pitavastatin will be used only if atorvastatin or rosuvastatin both are not tolerated. Maybe patient has myositis with both, and then you want to try another statin, then we will try pitava. Otherwise, usually for the vast majority of patients, rosuvastatin, atorvastatin will work. It is said that uh, atorvastatin is hydrophilic, while rosuvastatin is lipophilic. So rosuvastatin has a higher risk of myositis. Personally, I have not seen this difference in practice. How I decide is, if my patient has high LDL, I choose either atorva or rosuva. If my patient has high LDL plus high triglycerides, high LDL plus high triglycerides, then I prefer rosuvastatin. Rosuvastatin has a better triglyceride lowering efficacy. Dr. Vijay says how to treat TIA. So if your patient comes to you with TIA, so earlier we could actually wait. So the first thing I would do is I would check for hypoglycemia, hypotension, rule that out. The symptoms will be hemiparesis, hemiplegia. That is the commonest. But any other thing can come. Deviation of angle of the mouth, trigeminal neuralgia, twitching of the mouth, headache, postural hypotension. And if the patient doesn't improve within an hour or so, it's a good idea to send the patient for imaging. The immediate drug to use would be aspirin, but you have to rule out hemorrhagic stroke. So if the BP is very high, if there is even the slightest risk of hemorrhagic stroke, do the imaging first, only then you give aspirin. Because if we give aspirin in hemorrhagic stroke, we will end up worsening things. Vasomotor symptoms in menopause, the drug of choice would be MHT, menopause hormone therapy, provided that the patient is within 10 years of menopause or is less than 60 years old. If the patient has an intact uterus, then it should be estrogen plus progesterone. If the patient does not have a uterus, surgical hysterectomy has been done, then plain estrogen will work. Apart from this, the drug of choice is paroxetine, 10 milligram or 12.5 milligram at night, along with behavioral therapy. Greetings to Dr. Tala from Roorkee. Warm welcome, sir. Sir is a psychiatrist. And when diabetic patients complain of giddiness and falling like on walking, usually it is a postural hypotension, autonomic neuropathy. It might also be a sensory neuropathy that the patient doesn't know where he or she is walking. So you work up for autonomic neuropathy, also do a cardiac workup. Prediabetes, sir, is defined when the fasting glucose is between 100 and 125, or the random or postprandial or post-load glucose after a GTT is between 140 and 199. Lifestyle modification for everybody. Drugs we have begun using now if the patient has, along with prediabetes, severe prediabetes, sustained prediabetes, the patient is stout, that is obese, the patient has got established sclerotic disease, established atherosclerotic disease, or the patient has siblings. Remember family history, S is for siblings, has got siblings with atherosclerotic vascular disease or heart disease. So severe, sustained, symptomatic prediabetes with other risk factors like stoutness, smoking, with sibling history of ASCVD, that is also a risk factor, or with established SCVD, that is sclerotic vascular disease. Alzheimer's disease, I think social buffering would be the best. You make the patient socially active. There is no specific drug for Alzheimer's. Just recently, last week, the FDA has approved a drug, but I'm told it costs in lakhs of rupees per month. Specifically for Alzheimer's, you should rule out all the modifiable causes. Patient may be having hypoglycemia, may be having hypothyroidism, hyponatremia. These are the commonest from an endocrine perspective. Sodium, glucose, and TSH. These should be ruled out. Otherwise, we should get the help of a neurologist, and we should keep the patient socially active as much as possible. Dr. Deepak Rai Singhani states that statin is used for primary prevention above 50. That is true. You can give above 40 also. Aspirin is not used for primary prevention now. It is used only if the patient has got established ASCVD or established stroke, not for family history. The reason is that earlier we used to give, till 10-15 years ago, Now they have found that the risk of bleeding is very high with aspirin. It doesn't um, justify using aspirin for primary prevention. But statin should be given for primary prevention above the age of 40. A warm good evening to Dr. Yoglesh Uplenchwar as well. Which antiplatelet is tolerable? So routinely, Dr. Anshul, we use aspirin 50, 75, 150 up to us. If there is bleeding tendency with this, then clopidogrel 75 would be a drug to use. Good evening to Dr. Vinayak Sharma as well. And Dr. Tala shares a case of an obese 55-year-old lady, creatinine 1.8, urea 60. Okay, this would be probably CKD stage 4. And glucose is 300 on 4 antidiabetics, working with anxiety. So ideally, insulin is required because except for linagliptin, all the other drugs are going to trouble her. So explain to her that the kidney is in trouble. Let's give insulin for some time. Let us see what happens to the urea creatinine. We'll bring the glucose down and then see what happens. Some of the factors we can get from history. One is anxiety that is causing poor control. Second, probably this lady would be having a UTI, urinary tract infection, or a genital tract infection, pruritus vulvae. So take an empathic history. And on empirical basis, you might want to give nitrofurantoin 100 BD for a week, and also fluconazole 150 milligram OD for a week. She is 55, so she will be post-menopausal, and that also may be contributing to the entire problem. So just see if local HRT is required or maybe systemic HRT is required. Pioglitazone is emerging as a better choice for a reduction in IgG stroke. This is correct. Dr. Anshul is right. And we should not hesitate in using pioglitazone in patients who are at high risk of stroke. The only contraindication would be, number one, NYHA class 3 or 4 heart failure. Only NYHA class 3 or 4. And second, proliferative retinopathy. Dr. Tala prescribed metformin and glimepiride, that's fine. If we can get an HbA1c, sir, probably a third drug will be required. And maybe if there is no urinary tract infection, we can add an SGLT2 inhibitor. If you are not sure about the UTI or GTI, or you think the patient is not giving a good history, then linagliptin will be fine. But we must reduce the dose of metformin, sir. It is 2 grams is on the higher side. And with creatinine of 1.8, it would be a good idea to reduce the metformin to 1 gram per day. Thanks to Dr. Manu Sharma for being with us. And anxiety and palpitation in a person with diabetes. So earlier I used to use propranolol, but there is a slightly long list of caveats when we prescribe propranolol. You can't give it in asthma, for example. So check the pulse. The safest one, I think, would be bisoprolol, 2.5 milligram. That is what I would use. Or ivabradine, 5 milligram OD. So ivabradine or bisoprolol, ivabradine 5, bisoprolol 2.5. Start with that and see what happens. If the palpitations come down, anxiety will also come down. And thank you, Dr. Thala, for being with us. It is we who look up to you for advice. Okay, so Dr. Pramod Umarji says, why not use clopidogrel for primary prevention, if not aspirin? There also the benefit-risk ratio is not favorable. So aspirin would be first line for secondary prevention. If aspirin causes unacceptably high bleeding tendency, then clopidogrel. Clopidogrel doesn't act in everybody also, Dr. Pramod. Ideally, you are supposed to do a genotype. So now I have forgotten the name of the enzyme, CYP something. So CYP is something from the liver. If you have a particular allele of that enzyme, then clopidogrel will work. If you have a different allele, then that enzyme actually deactivates clopidogrel, so it doesn't work at all. Thanks to Dr. Kunal Kaushal for his kind words as well. So clopidogrel and statin combo for primary prevention not indicated. Dr. Sanjay Marathe shares this discussion. Statin alone. Clopidogrel and aspirin, that is called dual antiplatelet therapy, that is used only for a short period of time after a myocardial infarction or after a CABG. Role of carotid Doppler to prevent stroke in diabetes type 2. So carotid Doppler, Dr. Pramod, is not indicated as a routine investigation. But if you have patient coming in with TIA, symptoms suggestive of TIA, then the investigation should be done. And there is a treatment also, that is a carotid endarterectomy, if you find that there is an issue there. Dr. Sanjay asked about NOACs. Okay, so anticoagulant that we had in routine traditionally was warfarin. Warfarin is still the drug of choice in valvular heart disease and atrial fibrillation. Why do we want to give an anticoagulant? Because we want the blood to remain thin so that even if atrial fibrillation makes the heart release emboli, these emboli will not go and block the circulation. But with warfarin, there is a relatively high risk of bleeding tendency, and using the drug is difficult. Warfarin, digoxin, these are all drugs where you need a lot of attention to the patient. So, NOACs have been developed. These are directly acting oral anticoagulants, and these are much safer to use. They are the drug of choice in non-valvular atrial fibrillation. N for NOAC, N for non-valvular. If, let us say, you're in a primary care setup, you don't have access to neurology, cardiology, you cannot do a PTI, prothrombin time index, regularly for your patient, then I think NOAC is the safer drug to use. 3 drugs that we mentioned. If you were to remember one drug, I would suggest that you remember dabigatran, 110 mg. It is available from originator as well as Indian companies. If you are treating predominantly elder or frail population or renal failure population, then apixaban 2.5 or 5 milligram BD, depending upon the renal status. These are very safe to use. We will not use them routinely for thrombotic stroke. Do not use it routinely in type 2 diabetes. You will use them only if the patient has an arrhythmia and there is the high risk of embolism. Okay, now Dr. Fenendra says person has diabetes and has got stenting. Heart rate is high, 120, 130. So we have to give a beta blocker. This means adequate beta blockade is not being done. Choices would be, depending upon the BP, metoprolol 50 milligram BD, bisoprolol 5 milligram OD, ivabradine 5 milligram OD or 10 milligram OD. Any one of these should be given, not more than that. Also check if the patient is taking calcium channel blocker. Amlodipine, cilnidipine, they can cause tachycardia. Check if the patient is taking GLP-1 receptor agonist. Semaglutide, liraglutide can cause tachycardia. They increase it by 3 to 4 times. So stop these drugs. See if the patient is taking a cough syrup. Any treatment for asthma, salbutamol, these can also cause tachycardia. So stop these and start the beta blocker. Safest, if again you are in a primary setup, no support, safest would be ivabradine or bisoprolol. Okay, posture. This is from Dr. Poonam Grover. 1 minute. Postural headache and state of confusion, added irritability. What would you associate with? Okay, so not immediately with the stroke. Postural headache, state of confusion, I would personally think of hyponatremia first, low sodium with the irritability. Along with that, I would think of low glucose, hypoglycemia. So hyponatremia, hypoglycemia, hypoxia. These are the things I would think of. Stroke would be a second differential. It is an atypical presentation of stroke. Another common differential would be overdosage of any drug. Maybe we give pregabalin 75 milligram at night. Patient ended up taking 3 times a day. That can cause these symptoms. Taking a sedative or anxiolytic drug in extra dose. These are other issues. Maybe some drug abuse. So these are the things I would associate would be. But my first answer would be hyponatremia, hypoglycemia. Thanks to everybody. There are more questions. Dr. Shashikant Gajare says, rivaroxaban. Honestly, Dr. Shashi, I have not used in my OPD myself. I would suggest that you stick to 1 or 2 drugs and learn how to use them properly. But the advantage of using rivaroxaban is it is a once daily dose. But it has multiple doses. That's another issue. So it becomes a bit confusing to use. I have not used myself. I apologize. Dr. Khadirullah Khan, Adab Daksab, he says a patient using metformin 1 gram a day complaining of constipation. This is very common. So we have metformin 250 milligram tablet. You can ask the patient to take 253 times a day. Or you can change to pioglitazone. The treatment would be, the folk therapy we give is meetha soda, ek chutki subah sham, and then see what happens. Tell the patient to take curd, 100 to 100 grams 3 times a day. And now I do not remember the generic name. Pruvict is the trade name which I use. A very effective drug. Just give me a minute and let me tell you the the generic name. I need to remove my specs, sorry. Prucalopride is what we use. Prucalopride 1 milligram at night or 2 milligram at night. The drug is quite effective. This is a good drug for constipation. And meetha soda or baking powder, one thimbleful once or twice a day. This usually does the trick. More comments coming in. How to treat postural hypotension? Toughest part, Dr. Vijay. Really tough. So reduce the BP drugs. Prefer indapamide, which is a thiazide-like diuretic, or amlodipine. Indapamide or amlodipine, prefer them for managing BP. Keep the dose minimal. Um, ensure small, frequent meals. Adequate salt intake. If the patient is really in trouble, then tight socks. You might want to do a serum cortisol early morning, 8 a.m. If it is low, you can start hydrocortisone. If sodium is very low, then there are other drugs to treat sodium, but then patient should be admitted in the ICU. Another case that is shared is 60 years old, asymptomatic patient with HbA1c of 12, already on metformin and glimepiride. So we can add one drug, which would be an SGLT2 inhibitor or a beta blocker, but it is highly unlikely that the patient will come down from 12 to 7. So we should begin counseling this patient about insulin, especially if the patient is lean and thin or has lost a lot of weight. Also look for any associated infection or invasion. There might be some occult infection or occult tumor somewhere. The OADs we can use in obese diabetics, the drug of choice is semaglutide. So, but the cost is a bit on the higher side. 300 rupees per day roughly. You begin with 3 milligram once a day, given 30 to 60 minutes before meals, with a maximum of 100 ml of water. Semaglutide is the drug. Give it for 20-30 days, and then you go up to the therapeutic dose, which is 7 milligram, and then if required, 14 milligram. Most patients will respond to 7 milligram. Appetite will come down, weight will also come down. The second class of drugs is the SGLT2 inhibitors, which increase urine output. Dapagliflozin, canagliflozin, empagliflozin. Any of these to be given once a day. Canagliflozin 100 or 300 milligram. 300 is the best at losing weight. Dapagliflozin 10 milligram or empagliflozin 10 or 25 milligram, all once a day. FDCs are available of Cana, Dapa, Empa with metformin. In psychiatry, sir says we use a lot of atenolol and propranolol. Can we use in patients with diabetes on OHAs? Yes, but they might cause increase in insulin resistance. So if the aim is just to reduce the pulse and thereby reduce the stress, then bisoprolol and ivabradine would be safer drugs today. No hypotension will occur also with the ivabradine or bisoprolol in low doses. The H1C 11.5, 12 we mentioned. Begin counseling the patient about insulin at least, and don't go beyond 3 types of drugs. Acetron, Dr. Sanjay asked, that is the brand name for warfarin. So warfarin is the drug of choice for valvular AF, atrial fibrillation. You give 1, 2, 3, 4 milligram, but you have to titrate the dose according to the prothrombin time. You have to make sure that the prothrombin time remains about 1.5 to 2 times normal. It doesn't go too much and it doesn't go too low. It is quite difficult to use. It is not difficult, but if you have a lot of patients, then you should spend energy on this. Otherwise, Sanjay, it is a good idea to refer. What will happen, a lot of energy goes into counseling the patient. And in case there is any untoward incident, any bleeding or any embolism, then we will be blamed that you didn't give enough acetrom, you didn't give, or you gave too much of acetrom. This is known as a Goldilocks drug. Goldilocks drug means, you know the story. Goldilocks went into the forest and then she went into a house. So one plate was too big, the other one was too small, the third one was right in the middle, right perfect. So for acetrom and digoxin, you always have to be right in the middle, right perfect. And it does become difficult in a busy OPD to handle such patients. It is a good idea for this patient to remain under cardiac care. Thanks to everybody for so many questions and comments. And Dr. Vijay, your question was the toughest. How to treat postural hypertension? It is really tough. It is actually very tough. You can tell your patient to get up slowly from bed, not to get up immediately. So you can tell the patient, keep one pillow, two pillow, three pillows, get up slowly, uh, remain sitting in bed for a few minutes, and then walk. And then when you are walking or standing, don't stand for a long period of time. Sit down after every 10-15 minutes. So that also you can count. Dr. Vinay Desai asks, yes, imeglamin can be given with metformin safely. Start 500 milligram BD, go up to 1000 BD if required, and a very safe drug to use. In renal failure, also you can use it 500 BD or 500 OD. Last question we will take, if you allow. This is from Dr. Talha. Uncontrolled, sometimes controlled diabetes, okay. Non-obese lady, 60. If it is tubercular arthritis, then the HbA1c will be very high. Otherwise, she would not have got TB. Drug of choice would be insulin. If the patient has got any life-threatening, limb-threatening, or organ-threatening complication, then we must advise insulin. Insulin has anabolic effect. So if it is tubercular arthritis, I would strongly advocate for insulin, along with perhaps metformin plus linagliptin. If the HbA1c is excellent and otherwise the patient is doing very well and renal hepatic functions are fine, then any kind of OATs can be given. There would be no contraindication. But if the patient were so good, she would not so healthy, she would not have developed a tubercular arthritis in the first place. So I think we should consider insulin for at least 6 months in such a patient. Thanks to Dr. Sanjay for being with us. It's nice to connect with all of you. And I'd like to thank everyone for a very meaningful, very engaging discussion today. Thank you. And Karan is with us today. So Karan, how was your day today and how has the last 45 minutes been?
Sir, the day was very good, and after listening to such an exhaustive lecture with so many questions coming in, so many people asking so many questions, makes it more clear that so many people have so many people understood what message you have tried to share. It has made my day further a very pleasant day to close. In fact, uh, and to close this session, in fact, so I would thank Dr. Sanjay Kalra sir for such an exhaustive touching upon the topic, and it was a very common topic. But sir, I am sure you will also agree that it is something that every doctor comes across, and even after having seen so many patients, they still want to know more because it's a very difficult topic to cater to. So thank you so much, sir, for sharing this knowledge and this talk with us today. And on behalf of FDC, I thank all the audience as well to have joined us tonight. Thank you so much. Jai Hind. Good night.
Jai Hind. Jai Hind.